Hey everyone, thank you for joining us here tonight. My name is Kevin Anton. I'm one of the Interventional Oncology co-chairs for the RFS, along with Gabe Fine and Sam McMurray. And Tonight, as you know, you're here to listen in on a journal club. We have kind of a jam-packed schedule. Maybe we were a little overzealous with 3 articles, but I think we'll probably get through them okay. Our presenters are all set and ready to go, and we'll have some short discussion. I see Dr. Lewandowski and Dr. Brown both on the line, so hopefully they'll be able to stick around and moderate some of the discussion after each presentation. But hopefully everybody learns a little something, and we have a good time with this. I know the last journal club we had for the IO service line went really well, so hopefully we can repeat that tonight. So without further ado, our first presenter is Andrew Niekamp. At least I think he has his screen up now. Can everybody see his screen?
Yes.
Okay. Okay. So go ahead, Andrew, and then I'll adjust the presenter when we're done with yours.
All right. All right. Hi, everyone. My name is Andy Niekamp. I'm one of the radiology residents down here in Houston. So the paper I'm going to be presenting today, this is the development of the Hong Kong liver cancer staging system. Basically, its aim was a treatment stratification for patients with hepatocellular carcinoma. This article was published in the Journal of Gastroenterology in February of 2014. So a quick summary of the paper. The bottom line was the staging system had a significantly better ability than the standard in most Western hospitals, which is the Barcelona clinic liver cancer system, and it was better able to distinguish between patients with better overall survival times. The Hong Kong system identified subsets of the BCLC intermediate and advanced stage patients for much more aggressive treatments than which went on to improve survival times. So the major points here, they developed a classification scheme that associated treatment guidance mostly for Asian patients. This was a single center study for hepatocellular carcinoma, and it showed a survival benefit of radical therapies compared to transarterial chemo or TACE. That was pretty substantial, 52.1% versus 18.7%. It also showed a survival benefit of radical therapies compared with systemic therapies that was even more pronounced. This was 48.6 to 0. Criticisms of the study, though, however, like I said, it was a single tertiary referral center in Hong Kong, so it has a complete lack of external validity. A large majority of these patients, 80% of them, were hepatitis B infection carriers, which is drastically different from the patient population in Western cultures, which are HepC cirrhotics due to alcoholic disease and especially in America, NASH. The study was largely retrospective in nature, so obviously that opens it up to some pretty potential bias. So it was a retrospective cohort study. There were 3,856 patients with HCC, again, predominantly related to Hep B. It went on from 95 to 2008. And basically what they did from those years, from 95 to 2008, is they prospectively collected data, and they entered it in just a massive database. And this had variables ranging from demographics to clinical notes to laboratory values to treatments and survival data for each patient. So what they did is they looked back at this cohort of patients, and they basically randomly allocated them into 2 groups. They made a training set and they made a test set, and it was in an approximately 1-to-1 ratio. And I didn't put any of this information on the PowerPoint, but looking through the statistics between each group, they were very, very similar. So the inclusion criteria really wasn't a lot that they excluded here. It was all patients that had hepatocellular carcinoma that was diagnosed either by histology or cytology, an AFP greater than 400, or typical radiographic appearance, mostly by CT. And again, this was all done at Queen Mary Hospital in Hong Kong. The exclusion criteria, they did exclude 9 pediatric patients, and then only 63 because they died or were censored within the first 7 days after they got the study up and running, and they did not receive treatment. So again, the study aimed to develop a new prognostic staging system with associated treatment guidelines based on this large cohort from a single tertiary center. And then they wanted to compare this data that they came up with the Barcelona staging system, which again is widely used throughout the world. And basically what they did here is, this is the kind of the prognostic factors that they used to kind of create their staging system. They used ECOG performance status, the Child-Pugh grade. They went by tumor status, and then basically they wanted to look if there was any extravascular metastases, which were one of their big things that they were pushing for more advanced treatment. So patients were allocated into 2 sets. There was a training set and a test set, like I said, 1-to-1 ratio. They came up with the prognostic staging system and the treatment guidelines on just the training set. So they used that set, gathered all the data that had been prospectively collected from 95 to 2008, and came up with this, with their new prognostic treatment algorithm. And basically what the thing they were looking to do here is they really wanted to identify those intermediate or slightly advanced patients that were receiving non-curative therapies, and they wanted to kind of see if they could see if those subset of patients received more curative therapies, if they could receive a better overall survival time. So once they collected and created the guidelines and the outcomes for the training set, they then used that guidelines, tested it on the other test set. And so here we just, this is a pretty busy chart, but this is their overall flow that basically allocates people into these different stages. And, we have resection and TACE, so we have more curative therapies for a larger cohort of patients. And this is just for reference for everybody. This is the Barcelona Clinic Liver Cancer Staging System. Right here, basically, if you just see, if they have 3 nodules and they have associated diseases, they can still get RFA, which is curative treatments, but there are these intermediate and advanced stage. They go to palliative treatments. So they don't have any curative option based on this Barcelona Clinic Liver Cancer Staging System. So the outcome, again, was pretty substantial. It established this staging system in conjunction with this treatment algorithm, which applied to, again, hepatocellular carcinoma patients in Asia, mostly hepatitis B patients, that was able to significantly better distinguish between patients with specific overall times, and as well as identified a subset of the Barcelona intermediate and advanced stage patients that identified these patients who, under those guidelines, were receiving palliative treatments, and is now allocating them to receive more aggressive treatments. And like we said earlier, the improvements in survival times were pretty drastic. 52.1% versus 18.7% for the survival benefit of receiving radical therapies, and then 48.6% versus 0% for those who received radical therapies compared to just systemic therapy. So again, the most of the critiques of this, it's a 1 cohort study. There's absolutely no external validity to this, and it was all largely retrospective case. So there's a lot of bias that could be put towards this paper. However, it does set up a pretty promising staging system, and something that I think needs to be tested in a prospective cohort study, or large scale randomized clinical study to see if these results can be extrapolated to a real world scenario, as well as seeing if these same results were going to get applied to patient populations in the United States, which again are mostly HepC not Hep B, and are otherwise cirrhotics, alcohol disease, or NASH. So that is basically the paper, and open it up to discussion now.
So if anybody has any questions or comments, or just wants to start a quick discussion, just unmute yourself and just quickly identify yourself, and then go ahead and ask away. All right. So if there's no questions or comments, we will move on to the second presenter. We can always come back and revisit these papers later on. So I'm going to go ahead and change the presenter to Sri here. And then we'll make sure that we can see your screen.
Can you see my screen, sir?
Yes, now I can.
Okay. Should I go ahead?
Yeah, just click it into presentation mode, and then go ahead.
Where is the presentation mode?
Just the slideshow, I mean, on the PowerPoint.
Okay. I'm going to hide this one real quick. Okay. Hi, my name is Sri. I am one of the PGY for radiology resident at the University of Arkansas for medical science. So I'm reviewing an article which is from Hepatology Journal. It's a multi-centered randomized controlled trial of percutaneous cryoablation versus radiofrequency in HCC. There are a lot of articles in the literature saying cryo is more safer, but when compared to cryo with RFA, up till now the literature says the RFA is more safer than cryo. So this is the largest prospective study they did in China. This is basically, so the bottom line of this is HCC patients with Child-Pugh-ARB cirrhosis and with a HCC lesion less than 4 centimeters, and they have specific criteria with no more than 2 lesions in total. Percutaneous cryo and RFA are equally safe and effective ablation treatments for HCC, but the other conclusion they made was, but if the lesion size is like from 3.1 to 4 centimeters, their conclusion was percutaneous cryo is associated with a lower rate of local tumor progression than RFA, which is, the p-value is not so strong, but it's still statistically significant, and it should be considered one of the standard local ablation modalities in these patients. That's what they suggest. We'll talk about the conclusion, what we think at the end, but the major points are this is the largest prospective multi-center randomized controlled trial to compare the RFA versus cryo. We have several others. Some of the articles are, in the literature say studies comparing cryo with surgical treatment and cryo with liver transplantation, but never like a large trial to study RFA versus cryoablation. So, as I said earlier, prior studies in the literature says RFA was significantly superior to cryo in terms of complications and local tumor progression, but these guys try to support their things, saying that the reason these are equally efficacy is like because of the newer cryo probes that got into market and safer generation, and also improved operator experience and skill contributed to improved efficacy and safety of the cryo for HCC. But the major criticism here is the follow-up was only for 25 months. So like their idea was to up to 3 years, but the maximum follow-up was only 25 months. And I will show you later on the overall survival graphs and the local tumor progression graph from the study. But if you're given a large period of follow-up, there would not be a significant difference in survival between the two groups, and they are not, most of the comparisons are not statistically significant. The other important criticism is they did not analyze, which is the most important thing going right now, is like the length of hospital stay, the operating time, and the cost between the two groups, which is a big issue in current economy, I guess. So they did not compare how much cost the RFA versus cryo. And the other important thing is the study includes only HCC lesions less than 4 centimeters, but we did not know what's the prognosis of if it's more than 4 centimeters. So the type of study, actually the intention was 2,426 patients with a diagnosis of HCC. Out of them, the 621 met the inclusion criteria, but they only took 360 patients who choose to participate, were enrolled in the study, and they were given like a randomized either cryo or RFA, equaling the number of patients to 180 in each trial. And the time range was from February 2008 to October 2013. Their primary endpoints were like 2 things, like safety and local tumor progression at 3 years after treatment. The inclusion criteria, like the HCC lesion less than 4 centimeters, no more than 2 lesions, no extrahepatic metastasis, no invasion of portal vein, hepatic vein, or secondary branches, no prior HCC treatment, and they are strictly to child PU ARB, and ECOG performance status of 0 to 2, and no evidence of severe coagulopathy. The exclusion criteria, they excluded all the patients with uncontrolled or refractory ascites, and with ongoing variceal bleeding or severe hypersplenism or encephalopathy. As I said, child PU class C. Patients who prefer to receive surgery or liver transplant were also excluded. And if this HCC is within 5 millimeters of any of the major organs like gallbladder, colon, stomach, or CVD, were all excluded. So the purpose of this study was, as the growing data demonstrated, that cryo represents a safe and effective alternative therapy for HCC. But so far, there is no randomized control trial reported to compare cryo to RFA. So the main goal is to compare the efficacy. So there is a small table here, how they distributed randomly each patient, like cryo, and some of the patients first time they got repeated treatment. And if the treatment is resistant to both of these therapies, they went and used alternative therapies like TACE and ethanol injection. But the characteristics of both groups are almost similar, actually, in taking this. So here is a small description of how they did a cryo here. So the top row shows a dynamic contrast-enhanced MRI in a 50-year-old hepatitis B cirrhosis. It says there is a 2.2 centimeters HCC lesion, which shows typical washout in portal venous and delayed phases, which is characteristic of an SCC. And so the technique here they used was percutaneous access needle was inserted into the tumor. Then over the super stiff guide were inserted through the access needle. Then the access needle was removed, and they used 11 French coaxial catheter introducers. Sheath were inserted in the tumor through the guide wire. The guide wire and the dilation catheter were removed, and only the sheath. In the last image, if you see, there is only the sheath left, and they introduced the cryo probe to the sheath. This is all the technique of cryoablation. So this is an example. The top row is cryoablation, and the bottom row is radiofrequency ablation. You see in the top row, you see like a 3 centimeters HCC lesion. In the bottom is a 2.5 centimeter HCC lesion. The second B and D, top and upper and lower columns are immediately post-ablation on second day. If you see in RFA versus cryo, both the lesion disappeared, like complete resolution. But the C and upper and top left row shows after 6 months follow-up, there is recurrence in both the lesions. Okay, so outcome. The recurrence, overall survival, and tumor-free survival, the conclusion graph was, if you compare the cryo versus RFA, which the local recurrence was 10 in cryo and 18, but the p-value is not statistically significant. Even the new recurrence was not statistically significant. Given the below, there is a overall Kaplan-Meier survival graph between RFA and cryo, which is not even statistically significant. So these are some of the cumulative survival Kaplan-Meier graphs considering cryo and RFA. The only thing that was statistically significant was I put my green arrow there, which is overall survival. Not statistically significant, and the tumor-free survival is also not statistically significant. But if you see the distant intrahepatic recurrence, that was a little bit statistically significant. That is the only thing statistically significant in these patients. And if you see the child Pew class C, that is also statistically significant when compared with cryo versus RFA. So the outcome of their trial was therapeutic efficacy of percutaneous cryo was compared with RFA with HCC measuring less than 4 centimeters and no more than two tumors. So the end conclusion was both cryo and RFA were equally safe and effective with similar 5-year survival rates. However, there is no significant difference were observed either in the primary technique effectiveness rate, local tumor progression, distant intrahepatic recurrence, complications, overall survival, and tumor-free survival between the two groups. So I think the only thing there, that is the take-home message here is there's not a whole lot of research that's saying that cryo is much, but you have to see in the future how the cryo ablation will do for lesions in between 3 to 4 centimeters. The conclusion they said was like there is a statistically significant lower local progression than RFA, especially with tumor size of 3.1 to 4 centimeters, although they both have equal survival rates and efficacy rates. So we have to see how the two important things that we have to see is how much is the cost difference between the RFA. I think some of our experts here who are our panel should let us know, because in our hospital we don't do a whole lot. We do very occasionally the cryo versus, and we most commonly use the RFA. And still, when I spoke with my faculty, they still think they favor RFA versus cryo. But we don't have much experience with that. But in future, we have to see like how this is going to change the treatment modalities for HCC, especially when comparing RFA versus cryo. That's it.
Hello, can you guys hear me? This is Dan Brown. I have green bars showing on the microphone, so I just wanted to jump in here and answer presentation. Both presenters have done a great job. I want to give one credit. I'm going to go through just a couple of points about the cryo paper first. One is that cryo can be associated with excuse me. It's associated with more changes in liver enzymes in most studies. I'm not sure why it's different for this study. However, the changes in liver enzymes are not related to the tumor kill, but primarily margin that's created around it. And this was published by Brigham several years ago, where they noticed changes towards cryo-shock. And as of someone who did her cryo many years ago, I had some patients get serious liver enzyme, and it was also associated with margin. Final point. Given the work that it takes to get everything in place to do for cryo and these guys, you can certainly do it, but I don't know if it's necessarily the best idea to go through putting a middle wire manipulated track and do all that just to do a cryo could get equal efficacy with its RF and possibly. But I think the presenter did a great job. I was going to see Bob, and Bob's unmuted now, and I want to see Bob's any thoughts. Bob.
Yeah, Dan, I don't know if I have a ton of echo like you did. It was really hard to understand what you were saying. But I don't foresee cryoablation. I heard what you were saying, I understand what you're saying, but it's hard to understand. I don't foresee cryoablation overtaking RF or more importantly, microwave ablation for HCC during the liver. What Dan was talking about is the concept of cryoshock, which really was early in the technology of cryoablation with larger hepatic tumors, but some patients had bad outcomes because of it. The reality is that RF and microwave ablation are much more prevalent. More people have it. For number one, there's much more literature, even though this is a decent study. There's much more literature supporting both of those, particularly radiofrequency ablation. And then the speed at which you can do the ablation with microwave, particularly, is quite fast. With the cryoablation, where you have the freeze type cycle, it just takes a lot longer, and people really don't have the patience for that. And then if you can see the needles, applicators, antennae, whatever you want to use, the terms for the equipment we use are larger for cryoablation than they are for both microwave and radiofrequency ablation. So when you're talking about patients that have liver dysfunction and their INRs are elevated, their platelets are low, something to take into consideration. So, interesting paper. Most people have somewhat shied away from cryoablation in the liver. I think people are coming back to it. There is some application for it, was specific to the benefits of cryoablation, where you can see the ice ball, et cetera. So you may see a few people doing cryoablation, but I don't think it's going to overtake the heat-based algorithms.
Perfect. My apologies on the discussion after the first paper. I didn't realize that Dr. Lewandowski and Dr. Brown weren't able to unmute themselves. And I think everybody else is essentially defaulted into mute mode. And I thought about unmuting everybody so that you could ask whatever questions you had, and then thought about the chaos of the background noise that would ensue. So if anybody has any questions that they want to type into the comment box, I'll certainly bring those up for discussion. If anybody thinks that unmuting everybody and having you kind of mute yourselves on your own is a better idea, we could try that as well. Otherwise, go ahead.
This is Dan Brown. I called in on my cell. I heard I sound like Optimus Prime, and Lewandowski sent me a video of it, and I remember, so just for the staff and the resident fellow members, probably a good idea to have like a warm up about 30 minutes ahead next time, because I remember having problems with Macs in the past in certain headphones, and that's exactly what just happened to me. Sorry about that. So just keep going with the next one. And did Bob talk about the Hong Kong system paper?
I didn't speak about that one yet, Dan, so go ahead.
No, okay, I didn't know if you want to get to the next talk or whatever you guys want to do. If we want to do that now, that's fine. Bob, did you have any thoughts on the Hong Kong paper?
Yeah, I mean, the Hong Kong paper certainly got some buzz in the HCC world, and it is an interesting paper. It boils down to the Hong Kong paper is really hepatitis B patients, and the BCLC algorithm is for hepatitis C patients. So the reality is the Hong Kong staging system advocates more aggressive treatment for more advanced stages. So it's just treating patients more aggressively throughout all stages of the classification system, which I think a couple of things I have thoughts on. Number one, typically the hepatitis B patients have less chronic inflammation and less liver dysfunction than the hepatitis C patients, so it makes sense to treat them more aggressively. And number two, even though the BCLC algorithm exists, most people, and there's been publications on this, advocate for a more aggressive treatment in each stage anyways. So even though the algorithms don't say that, probably I would say maybe 20 to 40% of people actually get what's allocated to them. And many of the patients that don't get what's allocated to them are getting more aggressive treatment anyway. So maybe it's just a newer staging system, and that whole concept of being more aggressive is already there. The reality is that these algorithms are sort of recommendations or suggestions. And I think I saw somebody mention that, for instance, radioembolization is not in any of these algorithms, and nor is cryoablation, nor is bland embolization. Actually, neither is drug-eluting bead chemoembolization. So a lot of these things are local practice patterns, referral patterns, local expertise. There's a lot of modifications that centers make based loosely on these staging algorithms.
Yeah, I mean, I agree with that. I saw a couple good questions picking up on the bias of HB of patients towards hepatitis B, because it's in Hong Kong and that's what they have there. And we will have fewer resectable candidates in the United States because of HepC and NASH. The other thing I found interesting was I think it was group 5, the patients that got transplanted with who were ECOG 1 and stage 2 to 4, like the sicker group. They only lived a median of 12 months, and that's something that I thought was interesting, because that's a group that could possibly get without venous invasion, could possibly get transplanted here in the United States. And it's interesting that they did so much worse afterwards because almost everyone that gets transplanted here is really in the bucket by the time they come in, just because there's such a scarcity of organs.
Yeah, one thing I do want to comment on is that whole concept of ECOG performance status, and it's something you guys, the audience, should, if you aren't familiar with, should understand. And one of the benefits, particularly of the BCLC, is it takes into consideration not just the tumor. Categorizing HCC is confusing because the staging, if you just look at tumor staging, you're missing a lot of factors here, and one of the factors is the liver function, clearly, but the other is patient performance status. And patients who have symptoms from their cancer do worse than patients that don't. And we look at the ECOG performance status, basically 0 is people who have no symptoms, and 1 is people who have minimal symptoms and that aren't really affecting their life. And those could include some fatigue and pain, etc. Well, the problem is that many people, particularly with liver disease, may report fatigue, or you have a cancer in your liver. It could be 1 centimeter, but you could say, well, geez, I think I got some pain that's tweaked over there. I don't know what's going on. So if you falsely classify somebody as NECOG 1, if you look at the BCLC, you automatically move them into the advanced BCLCC stage, and those people should get sorafenib. And then really looking at, it really clouds the way you look at things. And you could take somebody outside of transplant and move them. You could say, well, they shouldn't get transplant, they should get sorafenib. Now, again, nobody would ever do that. But if you're looking at studies and papers, using ECOG as a criterion, you really have to understand how they decided what people were. And the intent is really having cancer-related symptoms, and sometimes it's hard to differentiate that from other symptoms.
There was another question that was asked before about the imaging type. They say in the materials they do mostly CT there as well. Should we have the last talk? Then we're gonna have open forum at the end, maybe, if we have extra time.
That sounds perfect. So we'll move on to the last paper. Let me switch it over to Allison.
All right, hey, I'm Allison. I'm a first-year radiology resident at the Walter Reed National Military Medical Center. This paper is called the Open-Label Single-Arm Phase 2 Trial of Sorafenib Therapy with Drug-Eluting Bead Transarterial Chemoembolization in Patients with Unresectable Hepatocellular Carcinoma. It's presented in JVIR this April. So the summary, this study contained 50 patients in which they combined continuous sorafenib therapy and on-demand drug-eluting transarterial chemoembolization, or TACE, in patients with unresectable HCC. It provided successful disease control and may have a survival benefit in patients with advanced hepatocellular carcinoma. HCC is one of the most common cancers worldwide, not as common in the United States. The third leading cause of cancer deaths, 5th most common worldwide. The curative treatments, of those curative treatments available, majority of the patients have advanced disease and are not eligible for resection, transplantation, or ablation, and that's where TACE plays a role. Prognosis is typically poor for advanced HCC. Most patients don't make it beyond 1 year after their diagnosis. So major points of the study included the 6-month disease control rate, which included the complete response plus a partial response plus stable disease, and this was 94%. Median time to progression was 13 months, and overall survival was 20.4 months. Criticisms of this study include confounding of overall survival when considering other standards of care once the patients were terminated from the study for whatever reason, having already undergone therapeutic interventions during this phase 2 trial could have affected their outcome, as they still tracked their progression even once they were removed from the study. Other criticisms include that patients with macrovascular invasion and asymptomatic extrahepatic disease and an ECOG score of 1 were included in order to reflect the patient population at most United States tertiary care centers, although this does not represent a very heterogeneous group of patients. Most of these patients were quite healthy. An ECOG score of 1 basically means you have minimal symptoms, can carry on most of your daily activities without any issue, without much effort. So the design of the study was a single center, single arm, open label phase 2 trial, and which means that both the researchers and the participants are aware of what is being administered to them. The 50 patients were diagnosed with unresectable HCC and treated with DEB-TACE from March 2009 to January 2012, treated in 6-week cycles. 1 week was continuous sorafenib therapy, followed by a TACE procedure. And the way they monitored the TACE was during a hepatic angiography during the procedure. Inclusion criteria included adults greater than the age of 18, and you had to have a diagnosis of unresectable HCC based on histology or cross-sectional imaging that demonstrated a hypervascular lesion within the cirrhotic liver or an AFP level of greater than 200. Your ECOG performance status could only be 0 or 1. Your child Q score was A to B7, and you had to have a life expectancy of greater than 12 weeks. Your total bilirubin had to be less than 3, and your serum albumin needed to be at least 2. You also had to have adequate cardiac, bone marrow, and renal function. Those who were excluded included those who demonstrated symptomatic extrahepatic disease, tumor burden greater than 70% of the total liver volume, and complete occlusion of the portal venous system, uncontrolled hypertension, and evidence of any bleeding diatheses or coagulopathy, or an active second primary malignancy. The purpose of this study, just to reiterate it, is to determine the efficacy of combined sorafenib therapy and DEB-TACE in patients with unresectable HCC. So the intervention, all the subjects had an unresectable HCC diagnosis. They recorded the baseline tumor evaluation as a liver mass that was greater than 1 centimeter based on cross-sectional imaging on CT or MR. And tumor response on follow-up was through triphasic CT or MR, clinical exam, and serum biochemistry 1 month following each treatment, and at subsequent 3-month intervals for the first year, and then twice a year with a combined clinical exam and imaging for a total of 4 years. The DEB-TACE consisted of 6-week cycles. The first week was continuous sorafenib therapy, which consisted of 400 milligrams of twice daily oral dosing, 1 week prior to the DEB-TACE, and then DEB-TACE was performed during week 2 of each 6-week cycle. Each DEB-TACE consisted of 100 milligrams of doxorubicin per procedure loaded onto 100 to 300 micron LC beads, and the total dose delivered was during the time of the procedure, during an angiographic study to assess the tumor vascularity. The endpoint was when the interventionalist saw a complete delivery of DEB-TACE or reduced flow of the feeding artery. Any one patient can only undergo a maximum of 4 procedures over the 6 months throughout the course. So the primary endpoint of this study was safety. Secondary endpoints included the assessment of response, time to progression, and survival. Complete response was defined as 100% tumor necrosis, with a partial response being greater than 50% of tumor necrosis. Progressive disease was defined as an increase in tumor enhancement by more than 25%, and stable disease present if other criteria were not met. disease control rate was defined as a complete response plus a partial response plus stable disease. And time to progression was defined as an interval from start of therapy to progression of lesions targeted by the DEBTACE procedure. And these are the details of how they performed the analysis. And all patients who received at least one dose of sorafenib were included in the analysis. The results showed that overall survival was 24.4 months, median survival 45.6 months for BCLC stage A patients, and 29.7 months for stage B, 8 months for stage C disease. For those patients who underwent more than 6 months of sorafenib therapy, their survival was 21 months. Those patients who underwent less than 6 months had a survival of 6.8 months. And this figure shows that the median time to progression in all subjects was 13.9 months. However, when the BCLC classes were stratified, median time to progression was 9.5 months for patients with stage C, 24.7 months for patients with stage B disease, and 27.6 months for those with stage A. And just a couple points that Dr. Lewandowski mentioned. This paper was sponsored by Bayer and BTG International. Additionally, the lead author of the study is an advisor and consultant for both, which could introduce an element of bias into the study. And my question for Dr. Lewandowski is, I know he mentioned that the ECOG status really included a group of healthy patients. Can this procedure and the efficacy translate to being used in interventional radiology procedures to increase survival of patients overall?
Yeah, so nice job, and you know, this whole concept of combining systemic and local regional therapy is an interesting concept. And to change the subject briefly, there was recently at the GI ASCO is a big clinical oncology meeting. I was here in Chicago over the summer. A very well done study sponsored by Certex looking at radioembolization. It was basically first-line chemotherapy for patients with metastatic colorectal cancer with or without radioembolization, a 500 or so patient study. Very well done. And when we start talking about metastatic disease, it seems to make a lot of sense. There are good chemotherapies. How do you integrate into the existing treatment paradigm? For hepatocellular carcinoma, there is one drug that's available, that it's in the guidelines, and that's sorafenib, which Bayer-Onyx makes. And so the concept is, how do you, or should you, combine sorafenib with local regional therapy? The answer is really not well understood at this point. There have been some studies, in bigger studies than this, that haven't been published yet, but that have been done. One's called the SPACE trial. And in essence, every study that has looked at combining sorafenib with local regional therapy has been negative. And what we saw in this paper too, you see the toxicity of the sorafenib, but there is no evidence that adding the two together increases the efficacy. There are different ways to combine local, regional, and systemic therapy. One, in this situation, they said they want to do continuous, so you're on the drug, you do your therapy. Another way would be to do the drug and then the therapy, or the therapy then the drug. So there are different ways to do it, or to discontinue, be on the drug, discontinue, and then do the therapy and then start it again. So there are different ways, and this is continuous. But this paper was not done at all to look at efficacy, and I think that in general, the comments about efficacy in this paper are overblown. You know, again, I'm not saying that there is any bias here, but you have to take into consideration that both companies, the ones that do the drug-eluting beads and one that provide the drug, it mentions that they sponsor this paper, so you don't know what that means. In some settings, that may mean that they collected all the data and they did all the statistics. You don't know that, so you have to understand where that comes from. I think that, one of the interesting things here, and I talked about performance status, they said that 48% were BCLCC, and that was based on or 48% of those that were advanced or BCLCC were based on the ECOG status. I find that hard to believe given the number one, the subjective nature of ECOG, as I discussed earlier, but also the limited disease burden that these patients had. The median disease burden was 10% liver volume. And when you read their methods, they said that the DEBTase was performed in a super selective fashion. So this wasn't low-bar therapies. These patients probably did not have a huge disease burden. So maybe they were not BCLCC really. Maybe the ECOG was not necessarily related to it. So I'm not sure that this is actually, they're talking about advanced patients. And when you talk about adding sorafenib into it, you should be talking about advanced patients. The other thing, and it's one of the things with sorafenib, but I think it's a little bit of a stretch to say this combination is safe, particularly safe. I think the efficacy, I think that's tough to say at all here, but I think if they want to talk about the safety of it, the median dose of sorafenib was basically half dose sorafenib. It was 400 milligrams per day, not 800 milligrams a day, which is the prescribed dose. And they stated that 94% of patients required dose modification. So is it really as whole dose sorafenib as it's supposed to be performed, and as what the trials that really put sorafenib into are the algorithms, is that safe with local regional therapy? I don't know. So I don't see this paper changing the needle at all, particularly since, again, the studies that actually were prospective randomized studies with or without sorafenib were negative. So it's in radiology, which is a nice journal, but I'm not sure that this really changes the needle for me. I just want to comment one thing. It's very interesting to think about adding something like sorafenib, which is a tyrosine kinase inhibitor, a TKI, with local regional therapy, from the standpoint that what we do know is when we do embolization procedures, bland and chemoembolization procedures, and maybe radioembolization, you are upregulating growth factors. Those growth factors, part of the process that drives that chain are things like VEGF and other markers like that, proteins like that. These TKIs work potentially by blocking VEGF. So, it seems to make sense that, it's one of the few times it actually makes sense to combine things. You combine something that has efficacy, the chemoembolization, with a drug that may prevent one of the drawbacks of doing the chemoembolization, which is upregulation of these growth factors. But again, the disappointment has been whether or not it's not the right drug, or we're not understanding it, we don't have the right proteins we're going after. Really, it has not shown. Most people think that it's okay to combine it, it's going to be safe, but it has not shown that it's going to be effective.
This is Dan, and I just had a couple other thoughts. I agree with everything Bob said. The one thing that kind of frustrated me with this trial, and the first version of it, which was in Journal of Clinical Oncology, which is an impact factor of like 18, it's a huge impact journal, is that there's a mix of BCLC A, B, and C patients. And, for all the faults that the BCLC system has, it does stratify intended survival. And you saw in this paper, A's did better than B's, B's did better than C's. So it's hard to see how much anything changed. And the C's did really poorly, although, they did notice that the most benefit was in the BCLC patients, and those guys should be getting sorafenib anyway. There's two randomized prospective trials going on right now, which are important. And one is an ECOG chemoembolization trial where all the patients are BCLC-B, and sorafenib is added into that group. So sorafenib is the experimental arm in that group. A separate trial, which is being run out of Bob's place, is a BCLCC patient group where Y90 is added in, or we're adding local regional to this. I think the one thing from the Hong Kong paper to try to tie some things together, there's more interest in using local regional therapies in people with advanced disease now. Y90's got good outcomes in that. And you could do super selective chemoembolization as well. I'm not quite as aggressive in treating large chunks of liver with chemoembo as I am with Y90. But the mix of the patients here makes it really tough to grade some of the stuff, and especially since it was a safety paper, the outcomes are like, I agree, they're overblown. And they acknowledge in the final paragraph that patients went on to get other treatments, and that clearly further muddies the outcomes, even though the patients had pretty much gotten all standard of care therapies by that point. One other thing in this that's interesting to me is a couple of the combo trials that have been done, either intentionally or retrospectively, or upfront or retrospectively, where they've used sorafenib plus some kind of arterial therapy, it's really uncommon that patients in these studies have tolerated full dose sorafenib. And I wonder if moving forward, if I was going to construct a trial with this, would I want to just construct it at 400 milligrams a day sorafenib? Because I've seen trials where patients got 400 milligrams a day, and they did better than expected. Because if you're supplementing treatment, you really need full dose, and that's one of the things that should be evaluated if you're combining treatments. Do you need to modify doses of some of the agents? And I think that's a thing that should be considered in future combined trials. And I mean, this is what medical oncologists do. We work with them, and they're, they always, whenever something works, they say, well, what else can we add to it to make it better? And we haven't found that yet for this, for chemobilization or Y90. But maybe at some point that'll come up.
So we had a couple questions that were sent in from our audience here. Maybe we could just touch on a couple of them briefly. One was kind of getting back to the cryo versus RFA paper, and David Petrov had a question about, I guess, whether there's been any discussion of whether IRE could potentially play a role in HCC, kind of in working its way into this cryo RFA microwave local regional therapy debate.
Dan, you want to give your thoughts?
I think IRE is still trying to find a home. I mean, there are places that do it well. If you're going to do it in practice, you have to have somebody that's able to spend a long amount of time doing the procedure. You have to have anesthesia. You have to have all the things lined up. And you have to have all the devices really, really well aligned. It's really not a forgiving technology unless everything is perfect. So I think routine use of IRE for liver mets, I mean, there may be places doing it for research purposes, and I know I have a lot of respect for what Raj has done in Miami, but, it's not something in our practice that's routine. I'm looking at IRE as a tool maybe to be used in pancreas, but it's not close to being standard practice as far as thermal ablation goes yet.
Yeah, I would agree with you. I think that, IREs, for those of you who don't know, has been around for over 10 years. It really hasn't, the technology has not been driven forward by any meaningful data or studies in general. It's been kind of a, hey, who's going to buy this? Who wants to market it and use it? There have been some high-level centers, though, that have taken the reins and done good research, but on their own accord and maybe getting grants, etc. The reality is, as I mentioned, one of the benefits of the thermal ablations being heating over the cryoablation was time. IRE just takes a long, long time. I don't foresee it ever overtaking thermal ablation in HCC. It may have a niche near a bile duct or other critical structure that you can't protect in other ways. There may be a few ways that they find a place to use it, but it's just I can't see it overtaking the other modalities.
Any other questions?
We have one other question here. Well, there's a couple, but one of the other ones was whether you thought there would be an impact on our treatment approach to HCC in the setting of hepatitis C with the new hepatitis C drugs that are coming out, like Sovaldi and Harvoni. Well, I mean, they're still doing a lot of chemobilizations with anti-hepatitis B drugs, and hepatitis B drugs can, when the tumors are controlled, that actually confers a really good survival. We had a small series we published out of Jefferson. We had a hepatologist from Korea there who had Korean immigrants to the East Coast would come see her from all over the place. And these guys were well controlled on antivirals. They'd have tumors, we'd treat them, and some of them lived 8 and 10 years after chemobilization, which is not typical for most hepatitis C patients. So I think it's an opportunity that maybe we can get better survivals. I think to getting at a point where hepatitis C is somewhat controlled in the population as well as it is in the Hep B population, we're at least 15 years away. And on top of that, the cost of the drug, there's an editorial in this month's Hepatology that just got released about the bottleneck of access to treatment
Because if you get cirrhosis from Hep C, the odds are your insurance coverage is not the greatest because you're probably pretty limited and you're on disability, and the drugs are hundreds of thousands of dollars, and some of the insurance companies are balking and paying for it. So there's a real traffic jam on this right now. There's a lot of ethics to work through, and this is going to be a very interesting issue to watch in the next couple of years.
Yeah, I mean, I agree 100% with what Dan said, and there's a lot of excitement for it, and when we start seeing patients that get cured of their hepatitis C, it's going to be 10, 15, 20 years before hopefully we see a decrease in HCC, although we see an uprise in NASH cirrhosis and other things, so there may be other reasons why people are getting HCC. A lot of interest is in doing highly effective therapies, local therapies for these cancers, and then putting patients on things like Harvoni, and hopefully you can cure the particular cancer they have and prevent them from developing new cancers, and as Dan said, maybe we'll see better survival, but that hasn't been proven yet.
Yeah, and I'd like to echo Bob's point about the NASH. I mean, I had pretty busy clinic this afternoon, and everyone had NASH. There were a couple guys that had Hep C too, but I mean, it's just everywhere, and it's not going away anytime soon because you can't fix that with a vaccine.
All right. Well, it's just after 10 o'clock here on the East Coast, so it's kind of getting late for everybody, and I just wanted to say thank you, big thank you to all the presenters. First of all, thank you to everybody who came out to partake, and a big thank you again to Dr. Lewandowski and Dr. Brown for coming to moderate and stimulate some interesting discussion. If either one of them want to say anything before we sign off, that'd be great. Otherwise, thank you again for coming out.
Thanks, guys. Sorry about the microphone.
Yeah, no, thanks. I think hopefully it was rewarding. It was a good discussion. So Dan and I both appreciate you guys and all the effort you put in.
All right, thanks, guys. So with that, we'll end. Everybody have a good night.